Welcome to the EADV podcast. In this episode, Dr. Sarah Walsh is joined by Dr. Sweta Rai, a consultant dermatologist and surgeon at King's College Hospital, London. Dr. Rai, who has an impressive training experience across Manchester, Yale and more, shares her journey with dermatology inspired by her father's surgical career. But before we get into that,
we are excited to announce you can now register for this year's Congress hosted in Amsterdam and online from the 25th to the 28th of September 2024. The EADV Congress is one of the largest international meetings in Europe focused on dermatology and venereology, and the packed 4-day program covers the entire spectrum of specialties. This is an excellent opportunity for you to join delegates from all over the world and exchange knowledge, network with like-minded professionals, and develop your career. Find out more at eadv.org/congress.
the conversation explores a recent Swedish study on complicated surgeries, with Dr. Rai offering a unique UK perspective on defining surgical complexity and the challenges posed by treatments like cryotherapy. Tune in for an insightful look into the world of dermatological surgery. Enjoy!
So hello and welcome to this edition of the EADV podcast. I'm delighted to be joined today by Dr. Sweta Rai, who is a consultant dermatologist and dermatological surgeon here at King's College Hospital in London with me. So we work alongside each other day by day. And Sweta is a very much admired dermatological surgeon in UK and European circles, having completed her training in Manchester, her fellowship in Portsmouth, and then subsequently post-fellowship training in Yale and Mount Sinai dermatology departments, so very illustrious locations. She's also got university roles at the Manchester University Skin Aging Programme and also here at King's College London, where she's in charge of undergraduate teaching for dermatology. So welcome, Sweta, and thank you for joining me. So I usually begin these podcasts just by asking you a little bit about what first attracted you to, firstly, to dermatology and then to the subspecialty of dermatological surgery.
Well, thank you very much for that very detailed and very illustrious introduction there. Thank you, Sarah. And it's an absolute pleasure to be, speaking with you today for the EADV podcast. In answer to your question, I always grew up in medical school believing that I would be more procedurally, practically better suited to medicine. So I grew up wanting really to do surgery of some sort, probably influenced by my father, who's a general surgeon. But when I arrived in the world of surgery, I thought that this wasn't necessarily a combination of the intellect that I wanted with the procedural aspect. And so I went to seek a specialty, which I believe dermatological surgery to be, a combination of intellectual diagnostics, intellectual thought processes, combined with the practical aspects of surgery. So I thought it was perfect for what I wanted out of medicine. So that's the honest answer, really.
So a little bit of influence from the family and then a little bit of exploration of your own in terms of the academic and the diagnostic. Fantastic. And, to facilitate today's conversation, you very helpfully looked through some recent publications in our journal, the JADV. To stimulate discussion. And the first one I'd like to kind of discuss with you is one entitled Risk Factors for Complicated Mohs Surgery in the South Sweden Mohs Cohort. First author Naturdal, last author Ingvar. And this was a really interesting paper that looked at it's over 600 cases in 11 years. So it's quite a large cohort, looking at the patient factors that determine whether Mohs surgery is likely to be complicated, as they define it in 3 stages or more. So I guess my first question is, did the findings of the study resonate with your experience from clinical practice, Sweta?
So I think I have to answer that in a few layers. So first of all, I thought it was a fantastic study because they looked at they're not the only ones to have looked at complicating factors in Mohs surgery, because Mohs surgery, as we all know, is very difficult to determine in its length, as well as which patients are going to be more complex, which patients are going to be easier. And often we do get surprised in clinical practice. But what I thought they did really well was that they they had good numbers, first of all. And they had a strict inclusion criteria. Now, in Sweden, I think looking at this paper, they exclusively, at least 444 patients that I read were of morphaic or morphaiform BCC. So their selection criteria for Mohs was stringent in the sense that they were doing more of the complex histological subtypes rather than the simpler subtypes. I think the nodular was less than 100 in the study. So I think, first of all, that's the major thing to mention. And this is why they have, and they mentioned this at the end in their discussion, that this may have influenced their findings, which differs from previous studies done on this topic. So it had good numbers, 444 morphaiform BCCs, and they found that age was an independent risk factor, and also number of stages more than 3 they classified as complex.
Can I just ask, do you agree with that definition for complicated being 3 stages or more?
So in England, we use complex dependent on tumour size. So in our practice here, we use tumour size greater than 2 centimetres on the head and neck, which is 20 millimetres, histological subtype, previously treated, so recurrent basal cell carcinomas, basal cells or squamous cells or other types of tumours with perineural invasion. So we go more on the histological subtype, and I think that's because it's in our guidance. For basal cell and squamous cell guidance. So we go on the histological subtype, but here they went on logistical factors, which I thought was interesting. So the logistics was that if you discount the histological subtypes and assume that most cases which are having Mohs surgery are complex tumours, which they usually are, otherwise they're often treated with standard excision techniques or other techniques such as destruction techniques such as curettage, for example, you are left with a more difficult cohort. And what I found, although this is not what we see in our practice, on average, what they found in their study was that most cases required 2 stages of Mohs surgery. So the predominant majority in that particular study was that on average, even with their morphaiform BCCs being heavily treated in Sweden, they found also similar 2 stages being the majority.
Mm-hmm. And you mentioned there other destructive techniques, and that was one of the things they looked at. Was they said previous cryotherapy was prognostic for a more complicated procedure. Can you just explain to the listeners why that might be?
So cryotherapy has known to be a form of treatment for basal cell carcinoma, less so now, more so maybe 20 years ago. But cryotherapy has been known to have a lower cure rate. So whenever we're counselling our patients for Mohs versus excisional surgery, I definitely quote that Mohs has got a 98 to 99% cure rate. We're looking at maybe a 90 to 95% cure rate for excisional surgery. And we're looking at much lower figures, maybe around the 70 to 80% mark for cryosurgery, curettage, depending on how it's done. So there is a definite discrepancy between the rates of cure. Now, also with cryotherapy or with curettage, it's individual variability. So how one performs cryotherapy, the freeze-thaw cycles that are needed, how precisely this is done, how precisely the tumor can be frozen to a certain temperature and then thawed and then frozen again. All of these determine a tumor's destruction. We have got better cryotherapy devices out there now which measure this, so therefore cryosurgery can be used successfully, but not to as high a cure rate still as microscopic controlled surgery for obvious reasons.
And is it because when you're interpreting, let's say, a previously treated lesion with cryotherapy comes to Mohs and you're looking at the sections, the frozen sections, is it that there's more scar tissue? Is that what makes the interpretation more difficult?
So we see more scar tissue with any previous treatment. That's first thing to note. Cryosurgery versus curettage versus excisional surgery, you get scar tissue developing. The principle of doing those is to examine 100% of the margin. So you have to go wider and beyond the scar to be able to have a true margin, to make sure you've not left any cells underneath the scar tissue, which become more difficult if there's any previous form of treatment done, including surgery.
Yeah, regardless of what it is. Yeah. I mean, one thing that really struck me, and it was a piece of information I really wanted to get from the paper that the authors didn't include, was they gave the relative risk of Mohs being complex after cryotherapy, but they didn't actually state the absolute number of patients who had previously been treated with cryotherapy. Because I would think, in a lot of places, as you say, cryotherapy probably wouldn't be used a huge amount in the management of BCC any longer. And so I would have been interested to know what the absolute number of patients who had been pre-treated with cryotherapy was. The other thing, and I'd be interested to get your thoughts on this, Sweta, is I thought that there was quite a large proportion of the repairs were full thickness skin grafts. And given that the average defect size was sort of 18 to 27 millimeters, I think that was the range they gave. Would you have expected there to be more flap repairs, primary closure? I mean, I guess it's difficult, isn't it, without knowing the actual sites, but...
Well, I guess there's a huge amount of individual variability on how one reconstructs their post-operative defects. Now, definitely through fellowship training, and this is the advantage of doing fellowship training, is that you get trained in a large number of Mohs cases, a large number of dermatopathology examinations, and also a large number of reconstructive cases. Historically, people have referred to other specialties for reconstructive surgery. That definitely was not the practice where I did my fellowships, and there was more of a impetus in my fellowships on the cosmetic outcome of a post-operative reconstruction. We know that flap repair, primary closure, sometimes even secondary intention. In fact, a lot of the time, secondary intention, you can get very good post-operative cosmetic outcomes. But I think skin grafts are the workhorse of plastic surgeons, and also skin grafts are for defect sizes where there may be discrepancy in form or ability of reconstruction to do a skin graft, because a skin graft is taking skin from elsewhere, relying on the blood supply of the recipient site to then absorb that skin. The skin match isn't likely to be as good as a local flap repair. But if you're doing a large volume of cases and reconstruction isn't a priority and cosmetics is not a priority, I would have thought that skin grafts is a very reasonable thing to do.
So I guess, Sweta, just to wrap up on that paper, what would you describe the take-home messages as?
So the take-home messages, I think, from that paper is, it is a good thing for them to have studied. Looking at complexity, looking at the cases that they had, they did a multi-center trial. I found what was really helpful was the age. I do see that in my clinical practice. And I also found it helpful that they were classifying things according to stages. But what I found really, really helpful was it was aligning with our current practice of, on average, most cases need 2 stages of Mohs surgery. Age definitely a factor. Other forms of treatment done prior to Mohs surgery definitely make it more complex, because you have to go wider and deeper than the scar. There is always a lower cure rate in Mohs surgery if there has been a previous treatment done, and we counsel our patients for this. So it was both reassuring, but also it quantifies the complexity.
Yeah, very good. So moving on to the second paper that you picked, which I also really enjoyed, entitled Accuracy in Anatomical Location on Dermatological Surgery, a Multi-Center Retrospective Study. First author, Constanza del Puerto. Last author, Christian Navarrete Deschamps. And I thought this looks at the accuracy of anatomical location and the documentation thereof. And I know that you're a real enthusiast for anatomy, Sweta, and I've been on the receiving end of teaching sessions from you employing teddy bears and skeletons and things like that, which has been wonderful. And I was really delighted to discover and explore the Delphi consensus resource referred to in this paper. And the most basic aspect of recording the anatomical site of a lesion is laterality. So is it left or is it right? And it has to be said, the Chilean authors did not come out bathed in glory in this respect, with only 57% of their lesions having left and right recorded, whereas at Sloan Kettering it was much, much higher. And the first thing that sprang to my mind when I read this was, I wonder what what patient record systems they are using in these two centres, because as you and I both know, having witnessed the painful gestation and delivery of a particular electronic patient record system here, when we record something, by clicking on the avatar, it automatically records left and right. So I do wonder whether that's part of the reason for this quite large discrepancy. And what was your take on that big difference between the two centres?
So my first take on this paper was that I was really pleased to see that, there are, as you said, using a Delphi consensus on anatomical location, because I think it's really, really important, especially in today's world of patient litigation, also wrong site surgery being such a common, well, hopefully not as such a common, but a widely reported error in, and with skin lesions, often patients have multiple skin lesions in different sites, which can be quite close to each other. So therefore, my interest in specificity and exact location, which we both know is very difficult in clinical practice to fully get right. But what I first noted was that the number of patients recruited, or the number of biopsies recruited from the Chilean group versus the Memorial Sloan Kettering group, I think the Americans had double the number of cases. So I think that's first thing to note. Secondly, there must be a huge difference in funding for both those health economies, thereby giving us a possibly different outcome, because we both know through electronic recording, you can get a more standardized, reasonably accurate, although arduous process of, recording our surgical sites and also taking photographs. So I thought those were the two things that stood out to me. But what really did stand out to me was that despite the differences in those healthcare economies, they both largely got the lefts and rights, so the laterality, reasonably correct. And also they got the Delphi greater than 4, I think, on the chest, which is a complex site, also correct compared to the Chileans. But it is interesting to see that even with our amazing patient management systems and electronic systems now, you don't get given a exact site. So we have an avatar on our system. We can click a site, but that doesn't automatically generate the site for you. You have to know the anatomical location. And
do you think we do that? Do you think we do that well enough? Do you think there's enough space in the undergraduate medical curriculum where we learn the anatomical vocabulary?
I certainly went to a medical school doing cadaveric dissection. I do know from training the undergraduates myself that cadaveric dissection and anatomy is being phased out, for whatever reason. I do also think that you learn anatomy, and you're learning anatomy through more technology-based devices now. There are lots of apps for anatomy. There are lots of technology resources that our students use. But you learn that in medical school, and then there is a long way till you actually join a dermatology residency. And in a dermatology residency, which is a predominantly medical specialty rather than a surgical specialty, it isn't, the onus is not on anatomy. And also, if you think, what I found interesting in this paper was that there was a discrepancy between the onco-dermatologists and the general dermatologists in their location identification. And I can only think logically that rashes or inflammatory skin conditions, you will know well, Sarah, they are more diffuse in their distribution, whereas cancers are more specific. And surgically minded people, myself included, are generally more
accurate in that regard. Yeah. As a medical dermatologist, though, I do take great pride in my precision of description. And Sweta, where do you think that medical photography comes into this? I mean, there are so many ways now that we can so easily record medical photography. Do you think that replaces the need for this precision of language, or is it just simply a supplement to it?
I don't think it will replace the need for language. Where I see the future heading is I hope to see this in the future in the generation of AI and technology advances, is that you have a photo, you upload it, and your avatar is able to put a name on that site. I do think so. Therefore, if you divide the body in a pre-populated format into anatomical locations, you click on that on your computer management system or patient management system, and it gives you a site. And then if there is discrepancies within that, then there may be subunits like we have in the face, for example, cosmetic subunits, which it could further specify things in. Yeah. And a photo would be used as a second adjunct to nomenclature. Mm-hmm. Because when our lesions get sent to a lab, the lab isn't looking at photographs. The photographs is for ourselves that we identify and the patient identifies with us the correct lesion to be excised. Mm-hmm. But the lab is always going to use nomenclature. I don't think the lab will move on to reporting with photographs.
Yeah. So let's exploit AI.
I think so.
And my final question for you today, Sweta, is just, can you give us a top tip from your surgical career for any aspiring Mohs surgeons out there?
Yeah, so I say this to a lot of our residents, and I would like to think that I practice this myself. I definitely traveled a lot to learn different techniques from different people, from different centers, both nationally and internationally. And I do think that has given me insight into some of the world's leading dermatological surgeons and the way that they conduct their Mohs services and the way they manage their resources, and are able to give high quality outcomes with very good processing times. And I do also think that has afforded, a greater experience in terms of, collaboration internationally as well as nationally. And I think I definitely would recommend that to any future budding
travel broadens the mind. Yeah. Dr. Sweta Rai, thank you so much for joining us today. It's been wonderful. And goodbye to our listeners. We look forward to hearing from you at the next EADV podcast. Thank you.
Thank you, Sarah.
A special thank you to all of our listeners. If you haven't already, make sure you subscribe on Apple Podcasts, follow us on Spotify, or you can find us on any major podcast provider. It really supports our channel. And we appreciate you joining us and look forward to presenting more interviews, research, and topics of merit. Until the next episode, take care of your skin.